Welcome, everyone. We will get started at the top of the hour. Well, good afternoon and good morning to those of us on the West Coast. Welcome to our third HPV vaccination best practice session. Today's focus is on provider interventions, and we are so grateful that you have chosen to spend the next hour learning, and we hope you find this session informative. Next slide. I'm Melissa Santiago, HPV Program Manager at the American Cancer Society, and I am honored to be moderating today's session. Before we get started, I'd like to review just a few housekeeping items. Our session today will be recorded, and the link to view the recording will be shared with all registered guests. Next slide. Today's webinar provides continuing education for providers, pharmacy, and nursing. We will be sharing today's information in the chat to claim continuing education credits momentarily. At the end of the session and in the follow-up email, so there will be 3 opportunities today to claim your credits. Next slide. If you'd like to get started now, please text 94553 to the number on the screen. This information is also in the chat, and again, we have multiple opportunities to claim your credits. Next slide. Our partners also value your feedback, so please complete the evaluation form on the screen. Next slide. We have an incredible program ahead with our esteemed partners who I will introduce shortly. And I encourage everyone to utilize the Q&A feature to post your questions. We have my colleagues who will be sorting through the questions as they come in. We have a very thoughtful agenda for today's event, and our speakers bring a wealth of knowledge and experience to today's best practice call. Next slide. Now it is my distinct honor and privilege to introduce today's distinguished speakers, who are thought leaders and change agents in the field of HPV. We will first be hearing from Dr. Ruth Stefanos from the Division of Viral Diseases at the National Center for Immunization and Respiratory Diseases for the Centers for Disease Control and Prevention. We will then hear from our longtime partner, Dr. Lauren Ng, Assistant Professor of Pediatrics at the Division of Primary Care Pediatrics at the Renaissance School of Medicine at Stony Brook University. Dr. Stefanos and Dr. Ng, thank you for being here with us today, and without any further delays, I give the floor to Dr. Stefanos, and remember to please post your questions utilizing the Q&A box. We will be addressing those questions at the end of the 2 presentations. Dr. Stefanos, the floor is yours. Dr. Stefanos, if you're speaking, we can't hear you.
Good afternoon, everyone. Sorry about that. Thank you, Melissa and everyone for inviting me to give this talk. Excited for the next hour to spend with you guys. So today I'll review the routine HPV let me see if I can turn on my camera. Okay, hopefully you guys can see me now.
Yes, we see you now.
Okay, perfect. Let me just go back to my outline slide. Yeah, I'm having a little difficulty. Okay, there we go. So today I'll review the routine HPV vaccination recommendation wording as it relates to vaccination at age 9 years. And then I'll review how CDC makes vaccination recommendations, and I'll provide a brief update on current plans. So this slide shows the current HPV vaccination recommendation. HPV vaccination is routinely recommended at age 11 or 12 years. Vaccination can be given starting at age 9 years. Since 2006, when the first HPV vaccination recommendation was made, there have been no substantial changes to this wording around timing of initiation. HPV vaccination has been considered part of the adolescent platform, which was introduced in 1996. At that time, an annual well-child check was not routine practice, and the adolescent platform provided an opportunity for 11 to 12-year-olds to get vaccinated at an established visit. In 2005, both Tdap and meningococcal vaccines were licensed and recommended at this age and continue to be part of the adolescent platform today. And in June 2006, the quadrivalent HPV vaccine was recommended at ages 11 to 12 years as well. So HPV vaccination has been promoted as part of the adolescent platform since its introduction. An example of this is on this slide. You can see language on CDC's website promoting this bundled approach. The HPV vaccine recommendation is depicted here in the familiar colors that are used on the vaccine schedule to designate the different types of recommendations. The yellow color indicating the routine vaccination for young adolescents, the green indicating catch-up vaccination for older adolescents and young adults, and the blue indicating shared clinical decision-making for adults older than 26 years. One of the special situations with the HPV vaccine is the recommendation for children who have a history of sexual abuse or assault to start the vaccine at age 9 years. This was first added to the recommendations in 2014. And here you can see the representation of the HPV vaccination recommendations on the child and adolescent immunization schedule. The yellow color shows the range of recommended ages for all children at 11 to 12 years. The purple color indicates the range of recommended ages for certain high-risk groups. For HPV, this would be for children who have a history of sexual abuse or assault to be vaccinated at age 9 years. And the depiction of the HPV vaccination recommendation wording of can be given starting at age 9 years is depicted on the schedule with a yellow and brown checkered color pattern. This slide shows how HPV is depicted on the parent-friendly, a more easy-to-read immunization schedule. Here, you can see the light purple represents that all children ages 9 to 10 years can receive the HPV vaccine. And the dark purple represents that all children 11 to 12 years should receive the HPV vaccine. The next topic I will touch on will be the Clinical Decision Support for Immunization, or CDSI project. The CDSI project provides resources that helps translate clinical recommendations into technical information to support consistent integration of recommendations into clinical decision support engines, such as electronic health records. There has been increasing awareness of how vaccine recommendations are interpreted in CDSI resources, and I'll briefly review this topic as it relates to routine HPV vaccination. So CDSI resources describe the logic for applying rules to clinical decision support engines. For HPV, CDSI resources use age 11 years as the earliest recommended age, which results in electronic health records and other CDS machines and engines prompting providers at age 11 for HPV vaccination. This is one of the implementation issues that some have described as a barrier to starting vaccination at age 9 years, although starting vaccination at this age is consistent with current HPV vaccine recommendations. As some of you are familiar with, CDC works with the Advisory Committee on Immunization Practices to develop vaccine recommendations. ACIP is a group of external experts that meet usually 3 times a year to review evidence related to vaccine effectiveness and safety. Committee members also review other pertinent information such as feasibility considerations. ACIP members vote on vaccine recommendations during these meetings. In addition to voting members, ACIP includes non-voting members from different organizations. The ACIP recommendation is then reviewed by the CDC director for approval. These meetings, ACIP meetings, can be viewed by the public. ACIP members also participate in vaccine-specific work groups. These work groups review data and present information and recommendation options for consideration by ACIP. There was an ACIP HPV vaccines work group for many years, but demands placed on ACIP due to the COVID-19 pandemic prevented reconstitution of this work group until recently. At the last ACIP meeting in June, it was announced that an HPV vaccine work group is going to be restarted. Prior to this summer, the last time this work group met was in 2019. So this slide was presented on that June ACIP call by Dr. Brooks, the chair of the reconstituted HPV vaccines work group, and can be found with all slides presented at ACIP meetings on the ACIP website. Among other policy issues, the ACIP work group will be reviewing evidence pertaining to wording of the age for routine HPV vaccination. Since some stakeholders are interested in vaccination at age 9 years, and while current ACIP recommendations are consistent with vaccination at this age, modification of the wording could allow more flexibility. In preparation for the work group, CDC performed a systematic review. Studies included in the review evaluated HPV vaccination series completion by age of initiation, evaluated interventions to increase vaccination at age 9 to 10 years, and were surveys or interviews of providers or caregivers. These data were presented at the National Immunization Conference earlier this month by my colleague, Dr. Sarah Brewer. In brief, data showed that children who start vaccination at age 9 are more likely to complete the vaccination series by age 13, probably because they have more time to do so, but a small percentage of children are starting vaccination at age 9. Studies were not able to evaluate whether recommending vaccination at age 9 increases overall vaccination initiation. Children who were vaccinated at age 9 in these studies may be the same children who would have received vaccination at age 11 or 12 years. Data show that vaccination at age 9 may be acceptable to providers and parents. Decisions on timing of vaccination might have programmatic implications, and that is what we are planning to review with ACIP currently. The work group will not be addressing other non-programmatic issues related to age at vaccination, but I did want to highlight evidence that we already know from prior studies. Prior data has already shown us that while the antibody response is higher with younger age at vaccination, there is no evidence that efficacy or protection is better with vaccination at age 9 to 10 versus 11 to 12. Another issue related to age at vaccination is preferences around number of vaccines to administer in one visit. While some parents may prefer not to administer multiple vaccines at the same visit, there is no evidence to suggest that receiving all adolescent vaccines at the same visit will diminish safety or effectiveness. This slide, too, was presented at that ACIP meeting in June. The other policy issue that will be considered will be the number of doses in the recommended HPV vaccination series. As many of you are familiar with, currently in the US, 2 doses are recommended for children who start the vaccination series younger than 15 years of age, and 3 doses are recommended for those who initiate the series when they are 15 years or older. Based on growing evidence, the WHO in 2022 recommended a 2-dose schedule and an alternative off-label single-dose option for 9 to 20-year-olds. In preparation For the work group, CDC has updated the systematic review that WHO performed on this topic as well. It's important to keep in mind that the ACIP decision on this policy issue may have implications on the interpretation of the data on routine age wording, since the definition of completion of the HPV vaccination series would be different depending on what ACIP recommends regarding the number of doses. So to conclude, we understand that the current wording for the recommendation, due to its translation into clinical decision support tools, may be a barrier for providers who are interested in vaccinating at age 9. It is expected that rewording of the recommendation will be considered by the ACIP work group. In the interim, it is important to remember that vaccination at age 9 is consistent with current routine HPV vaccination wording. The organizers of this talk asked me to provide the most up-to-date information on vaccination coverage. This is the latest vaccination coverage from the National Immunization Survey team that was just released last week. This is an annual survey that provides our most reliable estimates of adolescent vaccination coverage. This graph shows vaccination coverage of HPV and the other adolescent vaccines from 2006 through 2023 among all adolescents aged 13 to 17 years. HPV vaccination coverage is depicted by the purple lines for females and by the green lines for males. As you can see, HPV vaccination coverage continues to lag behind the other adolescent vaccines, and coverage has not increased in the last 2 survey years. A variety of analyses have been done to suggest that this plateau is due to the COVID-19 pandemic, and there are ongoing efforts to help catch children up with the routine vaccinations. So that last slide was looking at coverage by survey year, and this slide is looking at HPV vaccination coverage by birth cohort. This graph shows vaccination coverage by age 13 years by VFC eligibility. Many of you are familiar with the Vaccines for Children program that provides vaccines to uninsured and underinsured children, children eligible or enrolled in Medicaid, and children who are American Indian or Alaskan Native. HPV and all ACIP recommended vaccines are included in the VFC program. To quickly orient us, HPV initiation is depicted by the red lines, and HPV up to date is depicted by the green lines. The solid lines are VFC eligible children, and the dashed lines are not VFC eligible children. By age 13 years, coverage with at least 1 HPV vaccine dose and percentage of HPV vaccine up to date among adolescents who were eligible for VFC was higher than coverage among those not eligible for VFC in the 2002 through 2005 birth years. In the 2006-2010 birth years, VFC eligible and non-VFC eligible children had similar coverage. This higher coverage among those VFC eligible in the birth cohorts prior to 2006 was encouraging and illustrated VFC's impact in reaching populations with possible less access to vaccinations. Higher coverage was no longer evident in the later birth cohorts, though. Further work is being done to investigate and understand this most recent coverage data. So just like to end and thank Drs. Brewer, DeSisto, and Markowitz for their help with this talk. Thank you for the invitation to speak again. And yeah, looking forward to the Q&A session.
Thank you, Dr. Stefanos, for sharing your expertise with us. It was an informative and very timely presentation, especially with NIS-10 being released last week. Before we transition to our next speaker, I just want to make a very quick announcement that we acknowledge that the information shared to claim the continuing medical education credits is not working. We've informed the office, and stay tuned for further instructions. And keeping the momentum going, I now invite Dr. Ng to the floor to share with us some of the incredible work Stony Brook has implemented in the last few years. Dr. Ng.
Thank you, Melissa. Hello, everybody. My name is Dr. Lauren Ng. I'm an assistant professor of pediatrics at the Renaissance School of Medicine at Stony Brook University and at Stony Brook Children's Hospital. I'm here to talk to you about HPV vaccination best practices and provider interventions. Next slide. So a little bit about me. I am just a general pediatrician practicing in the outpatient world a little over the past 10 years. I live and work in New York. Um, and I guess I was asked to speak because I'm the principal investigator for the Quality Improvement Partnership to Improve HPV Vaccine Rates Start at Age 9 campaign. And I wouldn't be anywhere if I don't acknowledge my project team. So that's myself, Dr. Lori Ellis, who's another primary care pediatrician, and Dr. Linda Mermelstein, who's the Associate Director of Community Outreach and Engagement at Stony Brook Cancer Center, Barbara Messiter, who's our Partnerships Manager at American Cancer Society, and Alia Trask, Program Coordinator of Cancer Prevention and Action and the Community Outreach and Engagement also at the Cancer Center, and Doctors Patel and Doctors Fenton, they're residents, PGY3 residents. One is a pediatric resident, the other is a preventive medicine resident. And it just shows you how interdisciplinary this project has been, and not one facet is more important than the other. I need everybody to continue this project. Next slide. So our project history, we actually started this project in 2021. We piloted it at two offices, Smithtown and Center Moriches, and we participated in the American Cancer Society National Cohort of HPV vaccine quality improvement. So one of the things, besides getting our baseline data, we had identified patients due for HPV vaccine number 2. So our thought being is that if a parent was giving or gave the HPV vaccine number 1, then it was easier to get the patient to the office for that second dose. And that included physical callbacks from the front desk staff to get them back to the office for that second HPV dose, and or just make sure that they have an upcoming well visit so they can get that dose. We also provided in-person provider and staff education at the offices. And again, it was only 2 offices, so it's easier to do this in person. And part of the workflow change that we had made with the staff was trying to hand out the CDC preteen vaccine handouts to parents ages 11 to 13, just so that they know what vaccines are due. And that was also part of that patient education arm of that. In 2022, we implemented the interventions to all the offices. So at that site, at that time it was 6 offices, and we continued to submit data from the 2 offices to the ACS National Cohort. We continued provider and staff education. So it got a little bit tricky with 6 sites, and that included in-person, virtual, and video recorded education. Each education was tailored specific to that site. So every site had their own vaccine rates. And the reason why we did that is to kind of personalize the staff and the providers, because that's their home site, and to include them that this is, what we're trying to do specific to the site, even though it was all of the Stony Brook ambulatory sites that was getting the interventions. Our major achievement that year is that we had IT reports across all sites for our HPV vaccine rates. So prior to that, we were doing everything manually, which was time consuming. But with IT reports, it was easier to kind of gain our data and see what our progress was. We also continued patients due for HPV number 2 vaccine quarterly reports, and that helped us to do the callbacks every 3 months to get those patients back to the office. Next slide. So I wanted to just show you what population, I guess, geographically we were trying to target. So this is Long Island. All the yellow is Suffolk County. The stars represent the sites that we have in Stony Brook Children's. Like I said, in 2022, we had 1 site closed due to staffing issues, but now we have all 7 sites up and running again. And it does cover a vast geographic area. So in New York State, HPV vaccine completion rates by age 13 is 39.8%, and that was in 2021. In Suffolk County, where all our sites are, the HPV vaccine completion rate by age 13 is 29.4% in 2021. So there was a need for implementation and change to help increase our HPV vaccine rates. Also in Suffolk County, we do have a large population with cervical cancer. So again, the need to kind of protect our children. Next slide. So this is a copy of our CDC vaccine preteen handout. And it included the meningococcal, the HPV, the Tdap, and the flu vaccine. And that was just to portray that all vaccines are important. We don't want you just to receive one over the other, even though we were specifically looking at HPV vaccine rates. Next slide. And so now in 2023, we started the HPV vaccine at age 9 campaign. Our goal was to increase HPV vaccine initiation rates among 9 to 13-year-olds by 3% in 1 year. And that is the calendar year of January 2023 to December 2023. This probably wouldn't have been possible without the endorsement by our chair of pediatrics, Dr. Carolyn Milana, along with the support from the New York State HPV Coalition and the American Cancer Society. Next slide. So how did we do this? So first, our intervention number 1 was to recommend HPV vaccine at age 9. And this included education of providers, residents, RNs, LPNs, and MAs. So at Stony Brook Children's, our RNs and LPNs are the ones that actually physically give the vaccine to the patients. And prior to this year, I did have some hesitancy with some nurses saying, well, why are we giving it at age 9 or why are we giving it at age 10 when we routinely give it at age 11 to 12? But given that the policy had changed, and again, the endorsement from our chair, it was easier to educate everybody, including providers and nurses, that this is what's happening. We did have some hesitation with some older seasoned providers. However, as a division, since we were starting this, it was easier to get people start to change their practice. Our intervention number 2, if you think about like patient education arm, we had HPV vaccine rack cards developed to hand out for patients between 9 and 11 before their well child checks. There wasn't much information about or patient resources about starting HPV at age 9 at the time. So we had Cancer Prevention in Action, which is specific to our cancer center. They're supported by a New York State grant program with Health Research Incorporation that promotes cancer prevention. The goal for them was to develop and implement policies and practices, including increasing HPV vaccine rates. And I guess the other arm of them would be sun safety for protection of skin cancer. So the CPIA, or Cancer Prevention in Action, helped develop these or create these rack cards tailored to our population. And on the card had like a bunch of words, a bunch of information about human papillomavirus. And then there was also a QR code. They had developed a video specific to parents. This was a 3-minute video. So if parents, wanted to watch it or needed more information, they can click on the QR code as they're waiting for the provider to walk in the door, because oftentimes they are waiting. And again, if they had more questions after that, then they can talk to the provider once they walk in the room. Our last intervention number 3, included electronic medical record changes. So at Stony Brook, we use Cerner Power Chart. I know other health systems use Epic and Allscripts. But in Power Chart, we do have what's called Well Child Check Power Plans, ages 9 and above. So we added those HPV vaccine orders to those specific power plans. And I'll show you what that looks like a little bit later on. And that includes the HPV order to the nurse and the HPV charge or bill. And we also added that CDC preteen vaccination handout that I showed earlier to the patient education portion in our EMR, so that if a parent does want more information, we can click on the patient education and it can get printed up to the front desk in the DPARP packet when the patient checks out. Next slide. So again, like I said, the biggest portion really of our interventions was education to the providers and the staff. And I know Dr. Stefanos touched a lot about why at age 9 and, the stronger immune response, the younger you are, and being able to just have the 2-dose series versus, getting 3 doses after age 15. So I do have a lot of parents that don't agree to give it at age 9, which is fine. But I do also say at those visits, I will be recommending this vaccine at the next well visit, and just opening up the conversation to have with the parent if they have any questions or hesitancies. So I do believe, the earlier start, the better chance we are to have 2-dose completion by age 13. Next slide. And this is a schematic of our HPV rack card that I talked to before. It's very colorful and eye-catching. And then there's the QR code to that video. And then if you click again, it should show you where it says can be started at age 9. It was interesting, as part of like a New York State Coalition meeting, somebody had mentioned, like, can we have stronger wording than just can be started at age 9? But we just used that wording because at the time we didn't have any resources. Next slide. Okay, and then this is just a picture of our electronic medical record changes, like I said. So for every age, we have an order set to get through a well-child visit, and it includes the billing, it includes whatever screeners we have, so pediatric symptom checklist, any charges we need to put in, and then also the vaccines. So if you see the checked boxes, we have human papillomavirus, the actual order, and then the charge that would go to billing. So that way it's like a complete order set, and then you could be done with that visit. As Dr. Stefanos had said, a lot of EMRs don't have like, okay, due for HPV at age 9, and our EMR does not have that. And so this was kind of like a back around to like remind providers to ask about HPV at age 9, because oftentimes we'll pull up this order set in the room as we're talking to the parent and just say, and just look at the orders and be like, oh yeah, I forgot to talk about HPV. So we're trying to figure out ways to remind providers to talk about HPV at age 9 and above. Next slide. So what were our results? Baseline data for all 6 sites from 2022 compared to end of year data from 2023 showed an increase from 36.8% to 39.8% for HPV vaccine first dose rates from ages 9 to 13. And we did make our goal of that 3% small increase. But again, this is a total of all 6 sites. Our HPV vaccine completion rates from 9 to 13-year-olds were stable at about like 18.5% in both years. And thinking back on like if we improved our first dose rates, a lot of the children were not due for that second dose because it is a 6-month interval. So we just pretty much need to continue to monitor for more data points. And lastly, our most significant change was our HPV dose rate between 9 and 10-year-olds, pretty much increased at all sites. And this is easier to see at the next slide through our run chart. So this shows our baseline data in 2022 on the left. And then in 2023 on the right, that's when we started each intervention. Like I said, intervention number 1 is started early on in the year in January. Took about like 2 months to get everybody educated, and providers and staff included. Our intervention number 2, which is our HPV vaccine rack cards, came out pretty much at a good time because it was right before the busy well-child check season of the summer. And then you can see our rates steadily improved during those summer months, just because more patients were coming to the office for well-child visits. And like with anything technological or IT, that was the slowest to move. So we finally got those electronic medical changes in September, October. And again, it's hard to say if that even made a difference. I think, honestly, education was probably the most important difference that we made. And we just also need more data points for that as well. Next slide. So this is a very busy slide comparing 2022 to 2023. The only thing I wanted to point out here was that each site had different individual rates. So even though our total rates were averaged together, some sites had better HPV 2-dose rates than others. And it really just depended on, the size of the site and how many 9 to 13-year-olds they had at that practice. Next slide. So our goals for 2024 are continuing to encourage HPV vaccine initiation at age 9, continuing our provider and staff education. And with this, I do update providers on quarterly HPV vaccine rates at division meetings so that they know that we are making a difference and that, recommending at age 9 is actually working, which is encouraging for staff and providers. We're continuing patient education with those HPV rack cards that have been made. And I think at the end of this year or beginning of this year, I tried to get them into our EMR system so that also can be printed up at the DPAR process if needed. And we're also updating our exam room posters. So on the right-hand side is the poster that is currently hanging up in our exam rooms. And as you can see, it says, talk to the doctor about vaccinating your 11 to 12-year-old sons and daughters against HPV. So I had a parent, a 9-year-old parent who was in the room with me, and they had said, looked at the poster and then looked at me and it's like, why are you talking about HPV at age 9? My child is only 9. It says 11 to 12 on that poster. So then I felt like the need to update our exam posters was probably important for this year. We're also identifying race, ethnicity, and insurance. So that's private versus government in our results, and trying to see what our rates are with different race and ethnicities and what populations we might need to target more or educate more and kind of develop interventions based on that. Next slide. So I know this is a vast audience, and I just wanted to have some take-home points quickly to take with you. It's definitely important to advocate for policy change. So whether that's in a big institutional level or even in a small private practice, trying to implement change and start HPV vaccine at age 9, educating all the providers. Again, provider and education staff education is key. And just examine workflow closely to implement change. So your workflow might be very different from my workflow, and we don't want to take time away from staff or time away from providers to make this cumbersome for that. But it is important to kind of examine it closely and see where your interventions may lie. And then just again, project progress updates, just like with the division meetings and the quarterly reports. I just continue to show our HPV vaccine rates, how they have improved. And, lastly, like in doing this project, implementing change is a very slow process. So like I said, I've been working on this project for 2021 and I finally made some headway like 3 years later. So don't be discouraged. Next slide. And then if you have any questions, I really appreciate, listening to me, taking that time for me to have me speak today. This is my email if you don't want to talk in the chat or QA. And then I think my last slide is references. And thank you, everybody.
Thank you, Dr. Ng, for sharing those strategies with us. The success you've achieved at Stony Brook is truly a testament to the incredible work that you're doing, and I can't wait to see what you'll continue to do. Well, this was the perfect segue, learning about our policies at a national level and where we are as a country, and the work that we have yet to do with providers like Dr. Ng, who are at the clinic day in and day out, implementing these initiatives every day. We are now going to be moving on to our rapid fire Q&A portion. I'm going to invite my colleague, Dr. Gabrielle Darville-Sanders, Strategic Director at the National HPV Vaccination Roundtable, who will be moderating the discussion as we triage some incoming questions. So please do keep those coming in the Q&A box. Gabby, we had some really great pre-registration questions come in. So why don't we start by addressing some of those first?
Awesome. Thank you, Melissa, and thank you to Drs. Ng and Dr. Stephanos for wonderful presentations today. It's a pleasure to be in the space with you. As Melissa mentioned before, we had some questions that came in our pre-registration, so we're going to start with those questions. However, we implore the audience to keep asking questions. We have both presenters answering in real time using our Q&A functionality in Zoom. So Dr. Ng, the first question I have for you, really good question, really good presentation about the quality improvement work that you're doing with Stony Brook. The question that we received is, how can providers overcome unconscious bias?
Oh my God, that's a really hard question. So I think, honestly, it's hard to completely overcome it. I don't know if that makes sense. Just being able to recognize and to kind of take a step back and, sitting back and thinking about, okay, why am I thinking like this? I don't know if this really pertains to HPV vaccine, like unconscious bias with HPV vaccines, or but we do our best to deliver quality care. So the best that we can do, and then being able to recognize situations where, like, how could I have done this better? Honestly, I don't know if that makes sense.
It does. Do you have conversations in your quality improvement measures in your education and the training that you do? Do you have, or have you fostered conversations around any unconscious bias, or as it pertains to the work they're doing in the space of vaccination?
I don't know specifically in the space of vaccination. We do have residents that we train here. We do have a lot of education tools that we use. There is formal education, and then we also, by the institution, we'd have to do these modules about implicit bias and what to do in those situations. It's hard on the day-to-day, right? So we're seeing patients, we're busy, and maybe taking the time to kind of reflect on, okay, what did I do wrong today, or how can I help this situation? When I spoke to, let's say, this parent who lives in a shelter, or things like that. I think that is probably most important, one, recognizing, and two, how to do better.
Awesome. Thank you. That's a good question to answer. I'll shift it over to Dr. Stefanos. Same question for you. How can providers overcome any unconscious biasness that they may have relative to the work they do, but also in the space of immunization and vaccination?
Yeah, I echo your comments. It's a challenging topic, but a very important one. I think just, like recognizing all of our individual biases is important, but also establishing systems to ensure that all patients receive the care that they need. CDC doesn't necessarily have resources specifically to this topic, but since the vaccine was recommended, has developed materials to help providers communicate messaging around the HPV vaccine. And those materials have really emphasized not assuming anything about a parent or a patient's prior position on vaccinations, and really not necessarily recommending the HPV vaccine as like an afterthought or as an optional vaccine. But I kind of feel like unconscious bias it could warrant its own webinar and a whole another panel discussion.
Yeah, but really good responses, and it sounds like CDC has some materials that we can use, and so hopefully after the session we'll do a resource roundup and be able to provide that to our attendees for this webinar. So I'll move to our next question. We got a good list of questions in our registration. The second question is for Dr. Stefanos. How should we address concerns about the HPV vaccine in specific causing fertility issues and any other side effects?
Yeah, I think unfortunately, kind of fertility issues being linked to HPV vaccination is a piece of misinformation that we need to be prepared to discuss with our families and parents. There are multiple systems in place supported by the CDC and FDA that monitor vaccine safety. So not just the HPV vaccine, but all our vaccines are being closely monitored for safety. And there's nothing to suggest that the HPV vaccination causes anything concerning related to fertility. On the other hand, treatment for HPV-related diseases like treatment for cervical precancers and cervical cancers that are caused by HPV infection, those treatments sometimes can lead to fertility issues or complications with pregnancy downstream. So really, HPV vaccination has this potential to prevent possible fertility issues caused possibly by future treatments by HPV-related diseases.
Awesome. Amazing. Next question for you, shifting gears is just a little bit. There was a question about, and we've been getting some questions about booster. So if I was in the initial group that got the 4-valent vaccine, which I was in that group, and now we have the 9-valent vaccine, should I get a booster? Should I, especially if I'm at high risk for certain cancers, or maybe I've, been exposed in a way that increased my risk, or just overall, should I get the 9-valent vaccine as a booster to the 4-valent? And I'll shift it first to Dr. Ng, and then we'll shift it over to Dr. Stefanos. And if you don't have a full response, that's completely fine. But this is one of the questions that we got.
So I had to research this question because I don't deal with adults. I talked to multiple OBs who are in practice and, also work with OB-ONC. And they all said there's no harm in giving, the HPV 9-valent, and it probably is recommended just because you want to protect against the other types of HPV related strains or cancer strains. So again, I'm thinking that the booster is probably something we should give, the 9-valent. I don't know, Dr. Stefanos, maybe you can correct me.
Dr.
No,
Stefano?
no, I
Yeah.
think these are the types of questions that come in all the time. I'm also in that group that got the quadrivalent vaccine. So you're right. It's safe. We know the 9-valent and the quadrivalent vaccines, both licensed in the U.S., is safe. Since the end of 2016, only the 9-valent has been available in the U.S. But that decision to vaccinate in that adult population, it was just like I know went through quickly in my slides. So anyone above 26 to 45, so 27 to 45 years old, is the shared clinical decision-making recommendation. So there isn't like a universal recommendation, but it's something that should be made kind of on that one-on-one level with like the patient and their provider. But if you completed the series with the quadrivalent vaccine, there's not a universal recommendation to revaccinate. If you started the vaccination with the quadrivalent but didn't complete it, you may complete it with the 9-valent. That's definitely okay. But just in general, that adult population comes under a shared clinical decision making. So safe to give it and have a conversation with your provider.
Awesome. So we did get a question about age 9 from our pre-registration questions, but we also got some questions which I've seen we've been rapidly responding to. So I'll skip over that question just for time's sake. So we saw recent NIS teen data kind of show that there are some stagnant trends between non-VFC and VFC. So the question for Dr. Stefanos is, what does CDC want providers to do to address any VFC negative trends?
Oh, wow. That is a great question. I think, first of all, being a VFC provider is thank you. And if you have colleagues that you know can be a VFC provider, please have them become enrolled in the program to increase access. I think this is something that we just released this data last week. We're all still trying to understand it too and kind of think about our next steps. But I think my comments would be, make sure everyone who's enrolled in VFC can. And with your VFC patients, just like you would treat any patient, recommend the vaccine. Don't, just as I was saying before, it's not an optional vaccine. It's not an afterthought. But yeah, I think there'll be more to come on this as we've kind of like had the opportunity to evaluate our coverage data.
Awesome. I'm pinging from left to right because I'm trying to see if there's any new questions that we have. So one of the questions that we just got in is there any efforts to address any misconceptions or misinformation that exists around vaccinations in general? Is one of the questions. And I'll ping it over to whoever's willing. So Dr. Anna, if you want to answer.
Yeah.
Yeah.
So whenever I educate my parents, I kind of just say, HPV is a vaccine that prevents against different types of cancer. So that would be cervical cancer, penile cancer, head and neck and throat cancers. Just kind of globalize, like this isn't just like a sexually transmitted disease thing, like where, some of the misconceptions are, oh, she's too young, she's not sexually active, like that kind of stuff. Or a lot of the patients in our area are like, well, is this going to induce early sexual activity in young kids? And kind of just like being open with the parent, I'm going to have a 9-year-old soon and I'm going to vaccinate my son against HPV. That's even just a stronger statement to make too, because, oh, you're doing it, then it's okay. The other misconception is, does it make them infertile? Like, just like with the COVID vaccine. And honestly, parents are going to believe what they want to believe and they can do whatever they want to do for their child. But our job is to just educate. And, some parents don't want to hear it, which is fine. So we just move on. And I don't want to lose them as a patient. I do still want them to come back to the practice and do their well visits. So again, just not being like ultra judgy about it or, kind of just being open, essentially. Yeah. I don't know if that was
And as a
helpful.
follow-up to you, Dr. Ng, are there any special considerations or demographic considerations in the area that you live that you have to especially take into consideration with how you choose to recommend vaccination? It's just an interested, curious question. Yeah.
So it's funny. So when we look at our race ethnicity data, it says that, more the Hispanic population have higher HPV vaccine completion rates. We have a very high Spanish speaking population.
Yeah.
I feel like it's also maybe easier to get them to vaccinate because they're the outlook is, oh, the doctor's recommending it, let's do
Yeah.
it. It's funny, our white and Caucasian population is probably the lower end of HPV vaccine completion rates.
Okay.
And, again, it's hard to decipher why, we live in Suffolk County, we have a very vaccine hesitant population here. So again, I don't know if there's any specific pattern. I'm still trying to think of interventions that we can do geared towards, the white Caucasian population. But honestly, I think the persistence is also helpful, that we're open to talk about it earlier and
Mm-hmm.
multiple years after age 9. So like it's not like a push like you have to do this now, but like just so you know, I'm going to talk about this again next year. You can think
Yeah.
about it. Here's the resources. Just being open, really. And then also being open to listen. And people surprise you. Like I've had patients where I guess this is part of the unconscious bias where I'm like, oh gosh, they're not going to say yes, but I'll just say it because I have to. And
Yeah.
um, then they say yes. And then
Yes.
sometimes I ask if I have time because I'm seeing a billion patients at once. Sometimes I ask, so what was your driver on, giving the HPV at age 9? And the mom the other day had said, oh, I had HPV. And
Mm.
then I had another parent, oh, my uncle was just diagnosed with throat cancer. Oh, I had to get cervical cerclage. I had to do this. And so it's just very interesting what people's stories are, because we don't know, right?
Yeah. Yeah. And I think you bring up a good point, the impact of like the cancer on the family, right? And how
Mm-hmm.
that could be a driver or motivator. But I also think you bring up another point is that we see these national survey statistics on like, these are some common trends among Hispanics and Blacks and Caucasians. But within
Mm-hmm.
Stony Brook and the area that you serve, your trends are actually the opposite of what we
Mm-hmm.
generally see. And so having to work with that population to where and meet them where they are is kind of what I see that you are doing well with the work that you're doing. So kudos. Last question, because I also said I was going to ask Dr. Stefanos. So the same question for you. I think Dr. Ng provided us with really good sound bites and some strategies on how to address some misconceptions and misinformation. And so to you, how would you address any misconception, misinformation that may be there related to HPV vaccination?
Yeah, I think this is definitely a challenge, but not one that we can't overcome if we all are messaging kind of the accurate and consistent messages. We have amazing team members here at CDC and our communications team, and also across the center that have provided really great materials to support providers and people who are on those front lines, like delivering those messages. I think parents really trust pediatricians and other providers as trusted messengers. And so the more we can kind of equip the people who are doing that messaging that are trusted with the right resources, I think the better we can combat some of that noise. So yeah, I would say just leaning in to the trusted messengers is probably the best way we can combat some of that.
So, so I'll wrap it up here, and I want to thank you both for staying around and serving as our panelists for today's session. And I will shift it back over to Melissa, who will finish us off for today's webinar.
Thank you, everyone. That concludes our rapid fire session for today. Thank you again, Dr. Stefanos and Dr. Ng. Next slide. Well, on theme with today's call, some of these interventions were mentioned, and this is a really great summary slide of provider-directed interventions that your organizations can implement, and these include professional education, provider assessment and feedback, incentives, provider reminder recall, and standing orders. And it's important to note that these interventions are best done in combination. And we have a really great tool that highlights all of these interventions for screening and for HPV vaccination, which were adapted from the community guide available in the chat. Next slide. For those of us who are providers and part of care teams that are joining us here today, just want to reiterate that the best predictor of vaccination uptake for both hesitant and non-hesitant parents was how the conversation was started. So what you say matters, and how you say it matters a lot. Next slide. And it's crazy to think that 55 minutes have gone by, but we could not close out today's session without presenting you with some resources and some exciting opportunities. And of course, all of this will be shared in our follow-up email, and we'll be posting links in the chat as well. Next slide. This was referenced in Dr. Stefano's presentation, and it's a helpful visual for parents and guardians to have of the immunization schedule. Next slide. Also referenced was the immunization schedule for providers, which after today's presentation would be very timely to review with your providers and care team in your respective organizations. Next slide. The HPV Roundtable also has a great resource library that is constantly updated with resources and tools that you can use in your practice. Next slide. And for those of you who attended our first session, we had Dr. Noel Brewer share updates to the announcement approach training. They also have some great resources that you can use in your practice, such as this poster. Next slide. We also have some new resources that we are going to share with you today. Next slide. We are excited to announce that our action guide for health plans is now available on our resource center. The ACS and HPV Roundtable Health Plan Action Guide discusses the best practices for health plans on preventing HPV-related cancers through HPV vaccination. Next slide. And we also recently released the 2023-2024 HPV Vaccination Impact Report. This annual report highlights ACS's most recent efforts to continue working with our partners to end HPV cancers for everyone. Next slide. Next slide. And we invite you all to join us for our 2024 national meeting, October 7th through the 11th. We will be meeting daily from 12 to 1:30 p.m. Eastern to celebrate the incredible accomplishments the HPV Roundtable has had over the last 10 years. So please register in the link in the chat. Next slide. We also have a great opportunity for our rural partners in the audience. We have our learning community, which will convene again on September 18th. And the topic for this session will be on PDSA cycles, and we have a really great speaker, so please sign up for that. Next slide. And as you know, today was our third best practice session. We have one more remaining for 2024. And remember, we have continuing education credits for each of these. Next slide. Finally, we also want to announce that the 2025 National HPV Conference will be held April 15th through the 17th and will bring together professionals from all disciplines and backgrounds that will work towards eliminating HPV cancers. So please sign up. And if you're interested, please, there are still calling for abstracts and oral presentations. Next slide. We have an incredible opportunity to reach our teens and preteens with all of the work that we do, and your attendance here today is a really great first step. Next slide. As mentioned earlier, there are multiple strategies that your health system can take to proactively address vaccination in your communities. And here's a few for you to consider. All of these will be shared. I know I'm flying through all of this. I want to make sure that we get you all out of here on time. Next slide. But I do want to leave you with a call to action. If there's 3 things I'd like for you to take away today, it's this. HPV vaccinations have not fully recovered, and it's going to take a collective effort to see any increases. We heard an informative presentation from the CDC on the ACIP guidelines and what's to come. And this is the perfect opportunity to go back and clarify the guidelines with your providers. And it's crucial to evaluate and strengthen your current interventions to have the most meaningful impact. Next slide. We are also currently working on our 2025 learning sessions. So if you have a moment, please, we would really appreciate your feedback and love to hear what kind of topics you'd like for the following year. Next slide. All of this information will be shared with you in the roundup email, so please expect that. And again, I want to apologize for the confusion and for the texting not working. We have contacted the Continuing Medical Education office and they are working on it. We have your attendance, so please look for the email with next steps. And again, truly, we apologize for the inconvenience. Next step, next slide. Finally, this would not be possible without the support from our funders. We are so grateful for their ongoing partnership and support. Next slide. And I just want to say thank you to our speakers for sharing their time, their expertise, and valuable insights. Thank you all for your valuable insights and participation and your questions. It was a great dialogue today, and it's through these partnerships and collaborations that we can make a meaningful fight against HPV-related cancers. I hope to see you all soon and have a great rest of your day. Thank you.